So thank you for joining me and taking the time to watch and listen to this presentation about the creation of the Oxford Centre for Evidence-Based Medicine COVID-19 Palliative Care Group. What can we learn? I was thrilled to have the opportunity to talk about this because it's been a real highlight in this last year. We've achieved enormous amounts very quickly, and I do think there's transferable learning across to our sector in paediatric palliative care that hopefully we can make use of in the future. So what I'm hoping to cover is to tell you a story about the development of the group, to explore what we can learn from that might be transferable, and then just very briefly to signpost to some of the reviews that we've created. So once upon a time, just over a year ago, the COVID-19 pandemic hit the shores of the UK. 23rd of March, as we will well remember, we had our first UK national lockdown. Already at that stage, the Oxford Centre for Evidence-Based Medicine COVID-19 Evidence Service was underway, which is actually, looking back, is extraordinary. 26th of March, I got an email out of the blue from Professor Trish Greenhout in Oxford, asking if I'd be interested to give a palliative care opinion on a review that was already in progress. Little did we know where that would lead. So within 24 hours, she had linked me with Dr. Nick Jones, an academic GP, Professor Sandy Oliver, a social scientist, and we'd had our first conference call. And what we agreed actually is that we needed not just to give an opinion on a review, but to actually set up a palliative care core group under the Oxford CEBM COVID-19 Evidence Service to produce ultra-rapid reviews that would make a difference on the front line in COVID. And that's what we did. So a few days later, I liaised with Professor Max Watson with the Hospice UK COVID ECHO team, and they agreed to produce questions for us from their week-by-week meetings with palliative and hospice leaders across the UK, questions for review that could feed into our group, and then we could hopefully prioritise, commission and disseminate the reviews. So the 7th of April, we had our first weekly meeting of the core group, 7 of us. It grew to about 12 over the course of the months. And on that first meeting, we already had a draft review process agreed and the first 4 questions prioritised and draft PICOs. Extraordinary when I look back. And only a month later, we had our first rapid review published on the website, which was about the non-pharmacological management of delirium. So breathtaking speed. By the end of November, we'd produced 5 rapid reviews, 6 linked blogs, and 2 published papers. So just briefly to outline the process that was involved, we developed a question bank from the COVID echoes, from individuals who sent in questions, from other networks and organisations. On our weekly meetings, we prioritised those as to which were researchable and could make a real difference on the front line. Developed a PICO, did initial searches, checked that other groups weren't already doing it because this was very rapidly changing at that time, and then commissioned review teams outside our review group, but with 1 or 2 people who would link across and be part of each review team. So we looked for people with specialist interests in the relevant areas and set them free to go and do their review. We reviewed the review, acted as a peer review, and then were able to host the reviews and disseminate them on the website, and crucially back through the COVID ecosystem. So that was a wonderful learning loop. They gave us a lot of the questions and we were able to feed back the answers live as they were meeting week by week or fortnightly, and just add to their learning to take out into the front line. This is a list of the reviews that we produced between May and the end of November. And I think most relevant for paediatric palliative care, maybe the advanced care planning one and the work on transmucosal drug administration, but I'll come back to those in a moment. So what was the learning and what was the legacy from this work? Well, I thought there were 3 main groups of enablers that we could learn from for other work in the future: attitudes, resources, and function. This is a very busy slide, but I hope it's a reference one that you could come back to and think about. So there was a lot about the attitudes that we brought to this work, both individually and as a group. being collaborative, working with great urgency and speed, being so generous with time and with their attitude, being committed to the process, being very open intellectually as well as practically, being flexible and responsive, rising to the opportunity, learning a huge amount from each other, and being content with good enough. We weren't looking for gold standard, we just wanted to get the evidence out there as fast as possible. The resources that were brought to that were crucially, I think, our established relationships, both with individuals and with organisations, and an established dissemination vehicle. The CEBM COVID-19 webpage, yes, but also the COVID Echo system, and we were able to work very collaboratively with them week by week. Interdisciplinary input to the core group from academia, from the clinical frontline in palliative care and general practice, representation from lower middle income countries, health economist and PPI input. So a huge range of expertise, lots of time, access to an information scientist, and these online resources, being able to collaborate on Zoom, the Echo system, Google Docs to develop our questions and priorities, and a dissemination website. And then in the last column, some things about the function, which I think I've probably largely covered already. And these probably are the four key ones: the structure, the group process and role, the question sourcing, feedback, and having that live learning and dissemination loop via the Echo, and the CEBM webpage, which I think was really useful in commissioning teams to review, because we could say, look, we've identified this need for a review, it's come from the front line. If you're happy to do the review as quickly as possible, we will review it and put it up on the website, and it will get out there, and we can feed it back directly to the Echo. So that was very attractive for the review teams. A couple of limitations to mention: it was dependent on the CEBM funding of their COVID evidence service, which it wound down. So that really was a natural winding down of the work. We did look at other options, but by then a lot of people were finding they were committed more back in their usual roles, and those gifts of time were reducing. We're still working, but at a much slower pace. But the legacy continues. We have these new relationships for future work. We have new networks. We have this lovely, really simple collaborative model for research and dissemination and completing that learning and feedback loop. I keep going on about the Echo, but it's something that we are really at the beginning of in paediatric palliative care, and I think there's real opportunity to develop that. So that was one system for dissemination, and then having a dedicated website that people were going to for information also helped the dissemination process. And so much learning. I've learned loads about each subject, but also lots of process learning. So lots to celebrate. And then lastly, just to mention the reviews that we undertook. And again, this is mainly to signpost them. There isn't time now to go into them in detail. We had one on using non-pharmacological treatment for delirium, one on oxygen for breathlessness in COVID, one, this is a mouthful, on the role and response of primary care and community nursing in delivering palliative care in epidemics and pandemics. This was really to highlight a lack of evidence, but a useful springboard for future research. This one, I think, particularly relevant for paediatric palliative care about advanced care planning. So there's a summary slide here about the learning, and then some recommendations for health and social care workers and for policy. And I think I'd just highlight here the importance that came out of some of the reviews we looked at about multiple levels of influence: the individual, the interpersonal, the provider and the system. We've had so much focus just on clinician and patient and family with advanced care planning, but actually there's a lot of other work that we could do to help make that happen. And then lastly, to highlight this work on transmucosal drug administration as an alternative route in palliative and end-of-life care. Now, of course, this was something that we were able to bring from paediatric palliative care, and I was the paediatric palliative care rep on the group, because, of course, we've already done a lot of work on this. But what we hadn't done was a thorough review of the evidence, which actually is still in process. It's one of the ones that's still ongoing. And what we started off doing was producing with Professor Ian Wong and colleagues this article on transmucosal drug administration, really looking at the basic science. So it looks in detail at the main transmucosal routes: intranasal, oral transmucosal, and rectal. And it describes them physiologically, looks at the pros and cons of each. And then there's also this useful list about different drugs that we might use in palliative care and the existing evidence about their use in some of these different routes. I wish I'd had this article when I was working clinically on the front line in hospice and palliative care, because I think it would be a go-to article, so I can't recommend it too highly. Here's a list of the reviews we did and the 2 published articles for your own future reference. And it just remains for me to give huge thanks to Dr. Nick Jones as chair, to my colleagues in the Oxford CEBM COVID-19 Evidence Palliative Care Group, and to all the review teams who conducted all the individual reviews. Thank you so much for watching.